This video will discuss the basic aspects of quantitative EMG. It will cover the generation of multi-unit potentials, the different parameters, and the interpretation of the parameters.
The motor units in a normal muscle occupy a space of about 5 to 15 millimeters in diameter, and the territory of individual motor units overlap. The muscle fibers within a motor unit territory are distributed randomly. Here is an example of two motor units, one blue and one yellow, and the yellow one has its 50 to 200 muscle fibers connected and randomly distributed, and the blue motor unit is overlapping with that. In pathology, we have just a few types of reactions. In myopathy, we have smallness of muscle fibers and also hypertrophic muscle fibers with splitting of muscle fibers. We have reduced number of fibers and an increased interstitial tissue. This gives a weaker electrical signal to the EMG electrode. In situations of denervation-renervation, we have the following. Here is a yellow motor unit that is denervated, and the muscle fibers start to fibrillate, and they attract reinnervation from surviving motor units by means of collateral sprouting from surviving motor units. In this case, the blue motor unit therefore incorporates yellow muscle fibers, and it becomes larger and therefore also a stronger electrical generator. When we do the EMG, we have three steps. One to look at spontaneous activity, one to look at the shape of motor unit potentials, and the third step is to look at the recruitment of motor units and their activity at full force. The spontaneous activity I just mentioned briefly because we do not have methods for automatic quantitation here. We have normal spontaneous activity as insertional activity, end plate noise, nerve spikes, and positive waves at the end plate zone. And we have abnormal spontaneous activity either generated in the muscle, fibrillation potentials, myotonic discharges, complex repetitive discharges, and from the axon, neuromyotonic discharges, myochemic discharges, fasciculations, neurogenic extra discharges. And here we have some examples well known to all of you. Fibrillation potentials are single fiber potentials that are repeating with a constant, usually with a constant frequency. Positive waves is also seen in denervated muscle fibers. Myotonic discharges are increasing in frequency and amplitude, waxing and waning, both amplitude and frequency. Complex repetitive discharges are starting abruptly and consists of a number of muscle fibers that are completely time-locked without any jitter between them. These are from individual muscle fibers. And then we have the signals generated in the axon, indicated by the fact that they are motor unit potentials, not single fiber potentials. One is the neuromyotonic discharges, or myochemic discharges, which is a number of motor units that fire together in bursts of activity, and fasciculation potentials that occur randomly with irregular frequency. Now it comes to voluntary EMG. The discussion that we have here is true both for concentric needle electrode and for monopolar electrode. Here are the end plates and the electrical activity travels in both directions from the end plate. And here we have the single fiber potentials that are generated from each muscle fiber, with higher amplitude from those fibers that are close to the recording tip. And when they arrive at the electrode, they have a certain scatter, mostly dependent on different speed along the muscle fibers, which is directly related to the muscle fiber diameter. And when they are summated, they produce any shape depending on the dispersion. This is an EMG simulator based on data from literature. This is the cross-section of the muscle, longitudinal section of the muscle with motor end place here in the center. And here is a small blow-up area of a certain section. We insert the muscle fibers here, and we also insert a concentric needle electrode that I can move in the same way as we do with in our routine. And this particular position gave rise to this multi-unit potential. And if we move the electrode to another place in the muscle, we get other shapes of the multi-unit potential. So you see how in the same multi-unit we get any shape of the multi-unit potential. But when we run the consecutive discharges here, you see that for a standard position, the multi-unit potential has a constant shape. And now we are going to look at myopathy. So I have introduced fibers randomly and the electrode here, and we obtain this signal with in the normal situation. Is polyphasicity in myopathy due to loss of muscle fibers? Let's look at that. Here I delete one fiber after the other, and you can see the result down to the left here. Here we remove one fiber, we remove another fiber, we remove more fibers, and you see that the signal really doesn't become polyphasic, but rather more simple and lower in amplitude and shorter. Let's restore the multi-unit with a number of muscle fibers in the area. And now we make the other typical change that we see in muscle biopsy, namely fiber diameter variation and smallness of fibers. So we reduce the size a little, and particularly we change the fiber diameter variation. So now I arrange that, and you see all of a sudden we got this very polyphasic multi-unit. So polyphasicity in the early myopathy at least is due to increased fiber diameter variation. Put in the muscle fibers again, the electrode again here, and we record these fibers. And now we have the situation of re-innervation. That means that this blue multi-unit is re-innervating other surrounding multi-units that we don't see on the screen here, and the signal is increasing in amplitude as indicated here and become longer duration and higher amplitude. One typical thing is that we have fiber diameter variation because some muscle fibers have become atrophic while waiting for reinnervation. So I introduce smallness of muscle fibers and particularly fiber diameter variation. And here you see the polyphasicity that occurs. And another typical thing is that there is an uncertain neuromuscular transmission. So we increase that from 20 to 60. And then when we run the signal, you can see how the shape varies. And it's also a bubbling sound. That is the early ongoing reinnervation. So therefore the different parameters tell us different stories, and here are the parameters that we can assess visually or manually, namely amplitude, duration, number of phases, turns, and satellites and instability. And these parameters tell us about number of fibers close to the tip, total number of fibers within larger area, and temporal dispersion of the signals. And here, therefore, we measure the duration from start to end according to some special definition, number of phases above and below the baseline, or perhaps even more accurate to measure number of turning points, because not all turns dip across the zero line, so it does not produce phases, but the number of turns are many. So we talk about polyphasic and polyturns, or serrated or complex. But the other thing is that we can analyze these parameters with computer, and then we measure amplitude and area and duration and something we call thickness, which is the area divided by amplitude, and number of phases, rise times satellites, and so on. And that is done in the following way. The similar principle for different equipment. Here is an epoch of signals, 5 seconds or 10 seconds, and the computer is finding those signals that are identical in shape. This one, this, and this one. And they are placed in one memory box. And then we have another shape, this, and they are placed in another memory box. And all the signals in a given memory box are averaged, and we obtain this result. Here we got 33 of this signal type, with the average and the other disturbing have disappeared, and 29 of this and 21 of this, and so forth. And here is the final result, and we usually try to obtain at least 20 of the different multi-unit signals, with recording from 2 skin insertions and maybe total of 10 different recording positions. Here is a typical small section of recordings from a normal, very slight neurogenic situation with a slight increase in amplitude and smallness of the myopathic multi-unit potentials. The other thing that we look at is the instability of the multi-unit shape. We trigger on the signal somewhere here and superimpose, for example, 10 discharges. This is seen here on the top trace from a normal muscle, and this is from a patient with ALS, where we have great variation in shape due to unstable neuromuscular transmission in the reinnervating motor unit. This we call jiggle. Now we have so many parameters to measure. Is it really not possible to define that one of them is best and should be used routinely? We can look at that. Here are 2 situations. These are a group of patients with polymyositis, and here is a group of patients with ALS, recording from tibial anterior muscle. And you see that the amplitude on this slide varies from -3 standard deviation to +2 standard deviations, whereas the ALS has this variation, and some of these in myositis is definitely shorter than those in ALS, and those in ALS are definitely higher than those in myositis. But the problem is that we have a large overlap in multi-unit potentials of normal amplitude. The same thing with duration. In myositis we have some that are uniquely shorter, And in ALS we have some that are uniquely longer, but there is also an overlap between the findings. This is area of the signal, maybe a little better, and here is something we call thickness, area divided by amplitude, and here is a normalized area that we called size index, that they separate a little better. The conclusion is that there is no single parameter that is superior to the other in each case, but a combination of 2 or 3 parameters together can give a typical profile for myopathy and neuropathy. For all these things, it's important to have reference values from your own laboratory or from literature in case you use exactly the same technique and software as described for the collection of reference material. We don't go into the statistics of that right now. Only a reminder that reference values is a must. Some comments on the analysis of the EMG pattern during increasing force, that's called recruitment analysis, and during strong contraction, that we call the analysis of interference pattern. The different methods that we have available is recruitment analysis, visual inspection, spectral analysis, turns amplitude, and modifications thereof. The recruitment pattern can be analyzed by some parameters called onset frequency, recruitment frequency, and recruitment ratio, according to the following. Here is the start of the firing, usually with a low frequency of 6-7 Hz, and we talk about onset frequency, the frequency of the first motor unit when it is recruited. When we increase the force a little, other motor units are coming in, and when number 2 is coming in, we measure the frequency of number 1, and that is called the recruitment frequency. This is number 1 has 9 Hz when motor unit number 2 is coming in. Then we activate a little more, and when we optionally find that we have 3 or 4 or 5 motor units on the screen, we do the following. We look at the firing rate of the fastest, in this case 14 Hz, and then we see how many different motor units are there on the screen. In this case 4, and then we take 14 divided by 4, and the recruitment ratio is 3.5. When we now activate more strongly, then we have so much activity that we can no longer look at individual motor unit potentials, but use other techniques to analyze the interference pattern. When we have dropout of motor units, we have the following situation. The first motor unit is coming in here, but there is no second one coming in, and we increase the force even more, and then number 3 is coming in, now at a higher rate of number 1 than we had before, and that is called the recruitment frequency is not 9, but in this case 12, and the recruitment ratio is 5.3. And if we have a myopathy on the other hand, the other motor units are coming in earlier in the contraction, so the first motor unit has only a frequency of 7 Hz when the next one is coming in, and the recruitment ratio is lower than normally. This is called early recruitment, and here is an actual recording where we see first motor unit potential firing here, and all of a sudden a new motor unit here is coming in, and then we measure the frequency of the first motor unit between these 2 spikes, and we can measure the frequency when number 2 came into play. Now we can look at little stronger activity, and that can be done visually when we have a possibility to eyeball the total amplitude. Usually we cut away some of the highest and some of the lowest and assess an average envelope amplitude. And we see the fullness of the EMG pattern and low amplitudes. Here in the normal we have another amplitude, and we still have a full interference line. And with neuropathy we have even higher amplitude, and we have gaps in the signal due to a dropout of motor units. This is one way where we look at it and we listen to it. Another way is to measure the frequency content in the signal. In normal situation we have some low frequency and high frequencies of the individual spikes, and if we have a neurogenic condition we have less of the high frequency signals. They are larger and more bumpy. And if we have a myopathy we have many high frequency signals, and relatively speaking more of high frequency than low frequency signals. Another way to look at the interference pattern was introduced by Willison in the beginning of 60s, and with our modification according to the following. We measure number of turning points in the signal. For each peak we get a turn, so number of turning points per second. And the other parameter is the amplitude between turning points, amplitude between one turn and the next turn. And then we can plot the number of turns per second here and the amplitude between turns here. In myopathy we have lower amplitude, and here are 20 recordings in a given muscle at different sites, which is the typical situation. And here is our reference limits. And in neuropathy we have low number of turns, and many of the recording sites show abnormalities in the amplitude outside and above the normal limit. Here we have another situation where we have a rather severe myopathy with mainly polyphasic motor units, and they are also a long duration when we include the entire signal. And when we look at the individual motor unit data, here is amplitude and here is duration. You see that all the recordings except one is within the normal limits. So that was not very sensitive to detect pathology. But when we look at exactly the same muscle with the turns amplitude, then we see all the small spikes that do not show up in the MUP analysis. But here we see the low amplitude and the increase in number of turning points. So the two techniques complement each other. When it comes to central drive, when we have a stroke, spinal cord lesion, it is more difficult to detect EMG abnormalities. We can use the pattern of the EMG signals during moderate and strong contraction, the rhythm and the frequency and the stability of the firing rate. We can look at the fullness of the EMG pattern, usually reduced fullness, and that can be quantitated with a root mean square, for example. Or we can do combination of recording the CMAP during electric stimulation and the root mean square of voluntary EMG. In the central disorder we have a normal CMAP but a reduced RMS. And there are also other techniques that can be used. Finally, when we have different conditions here with neuromuscular junction problem myopathy reinnervation, axonal loss, conduction block, and central disorder. Single fiber EMG show abnormalities in all these three, and particularly sensitive to detect problems in the neuromuscular junction. When we have conventional EMG, we separate myopathy from neuropathy better than the single fiber EMG. And when we use conventional interference pattern analysis, we do not detect the changes in the neuromuscular junction, but can detect, in addition to the MUP analysis, also axonal loss, conduction block, and maybe a central disorder. We have a technique called macro EMG, where we measure the size of the motor unit. Motor unit number estimation is number of axons, number of motor units, and transcortical magnetic stimulation. There we also include the central pathways, and we can see the conduction block or axonal block along the way, but we do not differentiate between myopathy and neuropathy. The reason for performing quantitative EMG is that we get a standardized way of measuring, and this should lead and is shown to lead to improved sensitivity, and the results can be transferred from one time to the other in follow-up, from one physician to the other, and from one lab to the other when we collect reference material, and so on. We get better results also from less experienced, and it's actually helping during training to show how the cursor should be set and how the measurements should be done.
This was the end of the theoretical part of the discussion of quantitation in EMG.